Madam, shall we start the session? So, I think all of us will agree that labor is one of the most severe, labor pains are the most severe type, one of the most severe types of pain. And indeed, the laboring patients do need some form of analgesia, definitely. Whether it be non-pharmacological, pharmacological, that is immaterial. They need some form of analgesia. Because not only has it got an impact on the mother, it has got an impact on the progress of labor and the fetus as well. We'll come to all those in the subsequent slides also. So, but pain relief in labor, as we all know, is often an unmet need, especially in India, in the busy centers, because of a lot of different factors. And what we need in labor analgesia is for it to be safe, effective, and it should be available. And as somebody had said, to deliver a healthy baby to a mother who has gone through labor painless is one of the most satisfying things as an obstetrician. And they will remember you for your whole life. So, then when to counsel for labor analgesia, that should be long before the onset of labor during the antenatal classes, or at least when they are admitted for delivery. And what analgesia, that depends on the patient. We have to discuss everything. It should be choice of the patient. And we need a consent. And who should counsel? Obstetrician, and in high-risk pregnancies, probably the anesthetist also should be involved. And it should be a one-to-one counseling, or if as was in the COVID days, probably pre-recorded audio-visual aids and information pamphlets. So I will be going straight to my first scenario. I have got only one scenario for that matter. So we got a low-risk primary gravida, 39 weeks, 5 days, who's in spontaneous labor, and she is requesting for some form of pain relief. Susheela madam, what are the pain relief options she can be provided with in the different settings, and what are the non-pharmacological, pharmacological? Madam.
Yeah. I would like to start saying that pain is a very subjective symptom.
Yeah.
A lot of it depends upon the apprehension about the pain. When you start a labor thinking that it is going to be painful, it is definitely going to be painful.
Yes.
Believe me, I come from a community where many women expect that kind of contractions, and they go through labor, and sometimes not even with analgesics.
True, madam.
So the entire aspect of pain in labor is very subjective.
Yes.
And for some it is too much, for some it is bearable. Now, having said that, amongst the non-pharmacological methods, the commonly used ones are the continuous support in labor. Just having your very close one next to you itself makes it less painful, because you feel you're not alone in the pain.
Definitely.
And when that person is standing next to you, in the antenatal classes itself, I tell them how to be useful to the woman. Whenever she gets a contraction, I tell them to rub the low back. That is where the pain is intense. And every single woman says that it gives some relief. It may not give total relief, but it does give some relief in pain. The next, there are some who choose water bath. It is available in some institutions. It is not available in most places. Upright position, many women say that they are very comfortable in the upright position and the pain is much better, and I allow my laboring women to either sit up a little bit or even to stand up when they have a contraction. Only problem is, sometimes when the contractions are too close, the monitoring can become a little of a problem, but otherwise, these are the non-pharmacological methods, and I think this has to be used for most women. The other rarely used methods I don't even want to mention. Now, the pharmacological method, the drugs that we normally use and most of us use in labor are the systemic opioids. Many of us are used to giving pethidine, 50 or 100 milligram based on the weight of the woman. Fentanyl is something that can be given, but then that can be an intravenous, and so very, very, very few people are using fentanyl. Butorphanol is a good analgesic, but it causes severe sedation and therefore went out of repute. Pethidine and tramadol are two analgesics that are on regular use. And the advantages of this is that we ourselves can give. We don't have to depend on another specialist to administer analgesia. And the dose, we are all used to the kind of dose. One thing with pethidine is that sometimes it can cause a whole lot of sedation, and it can cause a lot of CTG changes. Unless one is aware that this can happen, you might wrongly interpret that there is reduced baseline variability, etc. And then it is particularly important to note that if she is going to be deliver within the next 4 hours, you probably withhold pethidine, because that can have neonatal depression. Now, when not to give is in hepatic disease, because it all depends upon the metabolism. The side effects, nausea, vomiting, sometimes we give it along with an antiemetic like ondansetron, or sometimes Phenergan 25 milligram. Sedation, dysphoria can be there, delayed gastric emptying, all these never pose any major problem. Respiratory depression also can be there, but I'm sure few of us have seen that kind of a respiratory depression, except probably in some of the neonates, and yeah, that's it. So generally the opioids are quite effective. Most of us are using it, and we are quite comfortable about it. It is safe. Serious problems are very rare. It is inexpensive, and you don't need a qualified anesthetist, and no great monitoring is required, unlike epidural. Disadvantages are they're good analgesics, but they are not the best. They don't totally cut off the pain. They are good, but they don't totally cut off the pain, and patient may continue to have pain, and side effects sometimes side effects can be troublesome. But generally, most of the places where, especially in the periphery, where you can't get an anesthetist to come for cesarean section, to come for epidural analgesia will be very difficult. So in those kind of situations, opioids are the ones that we use and are quite safe.
So I think most of us will agree, and we are so used to giving opioids to the patient as a first line measure. So, and as we have seen, they are quite effective, and there are a lot of advantages, but then that is not the absolute gold standard. So then what next, madam? If we don't?
Yeah, some of us use inhalation agents also. Entonox is the one which is most commonly used, and many labor institutions continue to use Entonox. This is a patient-controlled analgesia. So when she feels like she holds the mask, it's a combination of nitrous oxide and oxygen, and gives quite some pain relief. The side effects are very minimal. It is safe, it is reliable, you don't need to depend on an anesthetist, and there is no impact on labor progress or pushing effect, and it definitely does not have any adverse effect on the baby, unlike our opioid analgesics. And women's psycho-emotional experience of labor is therefore very good. So Entonox is making an entry again into our labor wards. I used to use Entonox long time back, but there are some institutions which are continuing to give Entonox, and it's good. It's good and gives patient satisfaction.
During the COVID times, we had a little bit of problem in getting the Entonox cylinders, but otherwise, Entonox does help quite a bit. Yeah. So, but this patient, madam, you want to say?
Okay. Yeah, I finished saying everything. The effective, safe. Yeah. It is simple. It is easily administered, and you don't need somebody. And she can hold the mask onto herself. And nausea and vomiting can be mild nausea and vomiting. Otherwise, I have not found absolutely any adverse effects with Entonox.
Yeah, only thing is make sure it's a patient-controlled analgesia, and you don't hold the mask on the patient. Yeah. Because once she is sedated, it will automatically fall off. Don't keep pushing it on to her face. But Madam Dr. Usha, Dr. Usha Shenoy is a professor of anesthesia from the JMMC. And Madam, what about if she is not satisfied? So she wants something more. So.
Okay. Thank you, Dr. Geetha. Yeah. And so this is an opportunity to address some basic questions and some controversies. The easiest question first, what is the benefit of epidural? It is the most effective way of pain relief available now for us. There are some fringe benefits for the obstetrician and for the anesthetist. For the anesthetist, it facilitates us to change the analgesic to anesthesia in case you want to do an urgent section. We can also avoid giving general anesthesia. As you all know, failed intubation and a difficult airway is one of the commonest cause of mortality, anesthesia-related maternal mortality. So if you avoid GA, that helps to save a lot of trouble. For the obstetrician, avoiding the tachycardia and hypertension because there's no pain, that has some benefits, especially if you have a patient with heart disease, preeclampsia, and say myasthenia gravis. And actually, when we started the program initially in our institute, we suspect we had a little more than normal patients with heart disease. We think our obstetrician's way of ensuring more close monitoring, that is why they asked for analgesia. And in centers where it is done more frequently, it could be used to reduce your section rates when you're anticipating trouble, like multiple births, a VBAC, or a anticipated instrumental delivery. Nevertheless, you need to have some precautions. Like before the procedure, all patients should have the routine hemogram. But if the patient has preeclampsia, make sure the count is done not earlier than 6 hours. If you note a low platelet count, less than 1 lakh and a decreasing trend, ensure the coagulation screen is done and it is normal before any instrumentation into the neuraxium. After the procedure, monitor the fetal heart rate, the BP, maternal BP, and the level of motor and sensory block, primarily because the side effects, undesirable effects are because of the motor block and you want to avoid it. Urinary catheterization, either intermittent or continuous, is essential, not for monitoring, but because she will not have the sensation and the ability to void. A distended bladder will, you know better than me, hamper the descent of the fetal head.
Now, so are there any contraindications, madam?
Okay, just as for a spinal, you have absolute and relative. Absolute is when the patient doesn't want it, when there's a coagulopathy, when there is severe mitral stenosis, aortic stenosis. And relative is when you have a patient who's screaming and uncooperative, it can be really unsafe. Sepsis and active neurological conditions too. Now, this is a very important question which many people want to know. When should it be initiated? Now, this is one point where the pediatricians, the anesthetists, the obstetricians, and midwives have uniformly agreed it should be given to the mother whenever she asks for it, which means it should be available 24/7. But what is more important to note is there's a lot of reluctance, especially to start this early in labor. There's a preconceived notion that increases rate of section. But as you can see, a meta-analysis of more than 12,000 patients has negated this. They said it does not increase this rate of cesarean delivery. So actually, we are depriving the mother, making her suffer pain, waiting for a particular cervical dilatation. It also makes it very difficult technically for us to place it in a squirming patient. And the only plus point you can see for us is when she's relieved of pain, and suddenly our popularity ratings may be more than yours for some time. So I think on your own good, you might want to initiate it early. She's anyway paying for it. Yeah. The commonly used drugs, we commonly use ropivacaine, very low concentrations of ropivacaine and bupivacaine. And we are able to, compared to previous days, we are able to come down dramatically on the concentration of local anesthetics because we are using adjuvants like fentanyl and dexmedetomidine. Now, combined spinal epidural analgesia is an offshoot where what we do is initially we give a very small dose of the drug in the subarachnoid space, a spinal, and it's maintained by epidural top-ups. And why do we do it? Because the onset is rapid. When do we do it? When you have a patient who's screaming with pain, with a lot of contractions, no gaps in between. So you give her some drug, let her relieve, and the pain is relieved, she's calmed down, you can place the epidural in a little more safer, comfortable way. And the catch is, again, because you have seen spinal headaches after cesarean sections, that's a problem here.
Yeah, madam. In this, when you combine spinal and epidural, I think you get a more compliant patient for the epidural.
Yeah, it's especially when it's done later on. If you're doing the epidural early, when she's not in active labor, just an epidural will do. But when the patient has decided very late that she can't bear it anymore, or the obstetrician wants to wait when it is active, this is a safer option. but it's more invasive. Then we come to walking epidural. It is just the same thing. When you give subarachnoid, the drug you give only an opiate or very low dose of local anesthetic so that there is little or no motor block. And why? Because many mothers don't like the sensation of numbness in their legs, the inability to bear down synchronously, they can't void, and they dislike it. And as Madam mentioned in her first slide, the upright position actually makes labor more efficient. The duration of labor is less, the fetal outcome is better, and the incidence of all this you know better than me. So that's why walking epidural is more popular. But what you need to watch out is you should make sure there are no obstetric or anesthetic contraindications to ambulation. She's able to perform a partial knee bending while standing. See, just because she has normal motor and sensory power, it does not mean her proprioception is normal. So you need to ensure that. Ensure there's no sign of orthostatic hypertension, and she should not ambulate unaccompanied.
Yeah, that was one thing I think Nusrat Madam had told yesterday, that that's why they are not too keen on the epidurals, because they have to have somebody one-to-one care.
Now the controversy is here. What is the effect of an epidural on the duration of labor? When it comes to the first stage, it's controversial. Some studies say it prolongs, some say it decreases. So there are a lot of mechanisms to explain both. And when it's controversial, what we can safely infer is that there are multiple factors involved in this, both anesthetic and obstetric. But among the anesthetic factors, compared to when it started, now we're using lower concentrations of the local anesthetic, and that has dramatically helped to reduce the effect of motor block in prolonging labor. But the point to note is the last line. Even though it is prolonged, there is no increase in the adverse maternal or neonatal outcomes because of the increased labor time. Coming to the second stage, there is no controversy. It is prolonged by an average of 15 minutes. But is it a problem? No, provided there's diligent anesthetic and obstetric practice. So we are doing our job in keeping her hydrated and pain-free, and you are doing your job in monitoring the baby's heart rate and the progress of labor. Things should be fine. Moving on to the effect on cesarean rates. Now this is an impact study. The dots on the left side are the incidence of section before epidural was established practice in an institute, and on the right side, the section rate after it was established. Now, these are in 7 different institutes, and you can see the lines are fairly horizontal. There's no big difference in the cesarean section rate after the epidurals. What about instrumental assisted delivery? Again, controversial reports, but the bottom line, there is no harm because of it. But by and large, I think we note an increase. Now, the most controversial question, because of this, should analgesia be withheld in the second stage? Medical evidence say no, there is no logic in doing that because there's no difference in outcome. The only thing you stand to, the mother stands to lose her sense of satisfaction. And what do? Considering that labor pain is actually not a sign of injury, it's an option, we give the patient a choice. We tell her the pros and cons. And very often she chooses to forego pain relief in the second stage. If she doesn't, then we consult with the concerned obstetrician and proceed as decided. The effect on neonatal outcome is practically no harm in both, whether it's epidural or not.
I think,
to conclude
we'll
with the
skip this slide.
complications,
Yes.
Do you have time? Can
I think we are running short of time. No problem, madam. I
Okay,
think we'll skip this one.
No, madam, we can take 3
I'll
more
go
minutes.
to. No,
You can
I'll go
take 3
to-
more minutes.
Okay.
She has talked.
I'll go to Dr. Nishi then. Madam, can you tell me about patient-controlled analgesia, as well as what are the options that you have, not on patient control, whatever you have in the busy center in India? So,
Patient control analgesia, because I already said it is a subjective phenomena. So whenever a patient wants to have an analgesic, when she presses a button or a demand button, she can receive an analgesia. That analgesia may be provided as an IV bolus dose. This is already a medication chamber, it is already set that so much of drug should be delivered when she presses the button. So when she presses the button, that amount of analgesia will be delivered to the patient. Then there is a lockout period. That is the time interval between the drug delivery and the next